Matthew Holt, the Healthcare Blog, back with Owen Tripp, CEO of Included Health. Owen, great to see you. We are now going to dive into, we talked a few months back about sort of Included Health and the strategy and all that kind of good stuff. Meanwhile, I have had your co-conspirators, Amy Parrick and Ankur Shah on, talking, the clinical team, talking about kind of the philosophy of primary care and how you figure it out and how you deliver care to populations and stuff. And in the background, you may have heard, and you've heard and you've written about, and the rest of the world has heard. There's this weird thing called AI and ChatGPT and Claude, and now Open Evidence and who knows what else, doing a bunch of stuff. So you've written a bit about this, and there's obviously a lot more to come about this. So let's dive in a little bit to both kind of your philosophy of AI, and then a little bit later, let's dive into how you think it might impact Included Health, because Amy talked a little bit about that as well. But I guess the first things first. There's a lot of different pieces of AI. Most of the money and the firepower, most of it in healthcare, has gone to sort of fixing the clinician experience, especially around ambient scribing and now extracting data. Now more and more that seems to be in the old world. Can we extract upcoding out of the text and charge more money to health plans who will fire back with their AI that will try and pay less money? Exactly. So we're seeing it being used for things that I wouldn't say either of us believe naturally are going to improve healthcare that much. But there is a fair amount of people starting to experiment with how can we make the patient experience better, the world you live in. So just give me your overall take, all the money that's been spent and raised and spent or not yet spent on AI in healthcare, health tech. What's your impression of where it's going and how it's been, what's been happening so far?
Yeah, I mean, you can almost picture a cartoon that, to my knowledge, hasn't been drawn yet. We could probably get AI to draw it for us. Where you have like the hospital executive using his or her AI to fire shots, requiring a case be paid for to the health plan executive who's using his or her AI to fire back, and the poor patient is sitting sort of down crouched below the desk trying to just figure something out. And I largely think that's a picture of the world pre-AI, and sadly, right now, it's a picture of the world post-AI, because you set it up, but I'm just going to say it even more directly. So far, artificial intelligence, as applied to healthcare in the United States and really around the world, is just being used to drive increased profit on existing transactions and workflows via clinician efficiency and other things that we can talk about. And it's been used to increase the revenue or value per event via things like coding, providing ancillary services that the patient or health plan need to have to pay for. That's not long-term a win for anybody other than the incumbents in the system. And so, as you know, and we talked at length the last time we chatted, this has always been true since I started the company. We are all about raising the standard of healthcare for the member. And we think a smarter, more powerful, more financially equipped member is going to get better outcomes for themselves in the market and in the healthcare experience. And then and only then can we find our way out of the morass that we all talk about. I think everything else, honestly, is just lip service to the experience. So what I'm excited to talk to you about today is actually how you put these exceptionally powerful technologies in the hands of members to get care faster that is cheaper to them. That's the win. That's the opportunity. So today, just to sort of set the landscape, at least as I see it for your listeners, I think you have AI driving clinician efficiency. We've yet to see that clinician efficiency result in lower bills to anybody else in the system. So you sort of ask where those dollars are going. We also see AI for drug discovery, and I think everybody should be very excited there. But I don't see drug pricing coming down, and maybe we need to wait to see if that happens. But I'm sort of doubtful. I wouldn't hold my breath. And now the question is, can I actually get answers and get care and get service as a member in a way that I don't need to wait in an office to get care, in a way that doesn't require me paying a copay to get a very straightforward medical experience, and that's where we're really leaning in.
So let's dive into that a little bit, because there are some nuances there, right? So we've had I would say, in the last decade or so, particularly the last five, up until 2 years ago, the last sort of 7 to 2 years, does that make sense? We had a whole bunch of people developing symptom checkers, patient front doors, trying to sell them to the health plans, some of the hospitals, have some of them being online already. And there's a lot of value in that. We also had a whole, for 30 years, and you've been involved and I've been involved for even longer, have had all kinds of stuff on the web of patient communities talking to each other, of the Mayo Clinic and WebMDs delivering information that was not available to anybody prior to 1995, essentially.
Yeah, I think that's true.
So we've had this big explosion in consumer understanding. We've also had a big explosion in consumer misinformation and stuff, but that's
absolutely topic.
Yeah. but we've had this ability to get information about stuff that you couldn't before. The symptom checker kind of thing has now been revolutionized by the LLMs. And now you're having a couple of things going on. One is patients going directly to ChatGPT and others and other sources and asking questions and treating it like a therapist. You do behavioral health, treating it like a skilled GP or even a specialist. Sure. You're seeing some people. I did an interview with Steve Brown, as another health tech OG, where he built a whole bunch of bots of different specialties to go to mine the LLMs to come back with what a oncologist would think compared to a GI doc compared to whatever. You've got obviously that's a direct to patient use of AI. Mm-hmm. Then you've got people trying to replace, at the moment, mostly customer service stuff with voice AI and chatbots, And then somewhere in the mix here, you've got clinicians of various flavors, whether it's people in the call center, all the way from navigators that you employ to clinicians in a call center to actual doctors, figuring out how to use AI in what they're doing. Which of those do you think is having the most impact at the moment? And where do you think that side of the equation is all going if we kind of ignore the upcoding, downcoding thing where we know most of the dollars are going?
So what's having the biggest impact at the moment? Did you start with the sort of generally available public?
I started with I feel something weird's going on. Let me ask ChatGPT. Or also,
if you ask me where the most impact is today, it's clearly there.
Yeah.
Point period. In fact, when you and I last talked, I think GPT-4 had just come out. GPT-5 has come out here in recent weeks, and there's a massive step forward in the healthcare literacy, multimodal capabilities, reasoning that are baked into that GPT-5 model. I suspect you're going to see concurrent moves from Gemini to match that. They frequently do, Claude, et cetera. So we have put, and by we, I really mean these companies that are sort of creating these lovely high compute models. We put really excellent tools to allow people to ask questions in plain English and then get answers in plain English. And now, because of the multimodal inline capabilities, you can look at videos and pictures and sort of reason with these things. That's terrific. None of them have yet sort of crossed a key stage that I think unlocks the whole market, which is it's actually personalized to me. And I really want to explore what I mean by personalization here, because if Sam Altman were here, he would probably argue these are deeply personalized. You can tell the model all about yourself, and it can respond in context to your culture, your language, your needs. And in that sense, conversationally, it's true. But it's not personalized with respect to my actual health history, my financial background, what my health plan will pay for. And to do those things requires a deeper connection into the personal data that exists that would allow it to offer that context. Because a question about my health and a set of symptoms I'm describing should get a different answer based on my health history than the same question from you or a 12-year-old girl. And that sort of sounds obvious to hear me say it out loud, but it's not actually how these things operate today. And to cross that piece would require patients license or, credentialing the AI directly into their health record and to do it across the health platform, which it'd be interesting to get your take on this, Matthew. I think that's unlikely to happen for a while, given sort of very appropriate privacy concerns. And it would also require, I think, an even harder step, which is credentialing the AI into my financial and benefits background. And you touched on this briefly, but if I have a healthcare need, it's one thing to sort of diagnose and recommend a treatment path or even suggest treatment paths as the LLMs do today. It's an entirely different thing to say, okay, and this is sort of how you obtain that service, or here's what you're going to expect to pay for it, or here's what is authorized under your plan. Those things are really actually hard to collect. And I don't see that the custodians of that data, aka your employer or your health plan or the federal government or the state government, I don't see them quickly providing that information to the AIs.
Yeah, I mean, in response to your question, I think that there is going to be a sub-segment. I think Steve Brand's thing is what I'm now going to have to look up the name of his company while I do this. It's CureWise, which is brand new. It's just him and a bunch of bots at the moment, but we'll be out raising money and all the rest of it soon. To me, there's a specialist group of patients who will, just as there was with the early days of the internet and cancer and all, who really dived in, really took over. There's a specialist group of patients who will do that and will exhaust every opportunity. And those with rare diseases or whatever will I think, are already diving into AI and using it. And I think a lot of other people are using it for general explanations and putting a bit of information about themselves. The idea of putting all your medical records in and, collect the kind of thing that you guys were doing in the early days before there was real access where people were faxing in or sending in by carrier pigeon, you were sort of collating everyone's medical records and all their information, then having a review team look at it. Doing that and putting that into the LLMs is easier now than it was, and maybe with Epic, doing a solo my chart, it might be you can get all stuff. It's easier, but that's still a big step for people to take. And the other thing you mentioned is right now for those LLMs, they're not HIPAA certified, privacy, right? You're putting your stuff in and it's going to train on it unless you stop it. And in some cases, it might share it with the world unless you.
Exactly.
That we have to work on.
No, that's a terrific point. I mean, I was positioning the polemic as just from the perspective of the member and in her interest in privacy and sort of making sure that you're not sharing data that could travel. I think there's an equally, if not larger, problem on the side of the LLM because they then become liable for all of that data,
right?
In a way that you and I are very aware of what the HIPAA breach penalties are, the federal reporting requirements. I mean, at the usage of these companies, even with as much money as they've raised, that is a massively expensive event.
And by the way, let's add one more in. As people are using these for therapy, there are now claims that it didn't react quickly, and there was an article in the Times literally about somebody who committed, a young woman committed suicide, having confided in ChatGPT a lot. Now, ChatGPT did say, go talk to somebody or talk to your parents, and she did do it. But then, when they actually went and read the whole thing, you could argue we haven't had the legal ramifications of that yet.
Yeah, I mean, just sort of on that point, I don't know the current statistics, but I know that at our scale and volume, multiple people per week indicate suicidal intent across all of our care and service lines. And we have literally a red button inside of the app that allows us to notify emergency services to get people to that location. It's actually one of the, I think, beautifully powerful ways of having virtual engagement is because you can actually figure out where that person is and sort of take care of them. Here's the thing that I think we don't want to speed past, though, which is, the data that is shared with these LLMs can be used for all sorts of other training data sets, including, pharmacy companies that want to discover and create new compounds, based on your health history or your experience. Soon, I suspect people will, upload genome data into these things. And I think that represents a real privacy risk. And everybody is going to want to use it in these ways. Like I came out of, as you know, I came out of the early days of consumer internet. I've built consumer-facing applications my entire career. I continue to build them here. Obviously, it included health. It is my passion and my knowledge set. And one of the sort of axiomatic things is if people love using something and it's easy, especially when it's basically free, they're going to continue to do that. So it's not, it's not usually great for the propeller heads like you and me to sort of speculate that they shouldn't or won't because of these privacy things that they're largely unaware of. And more, we need to think about like how do we make a better version of that that actually can solve all the problems. And so this may drift a little bit into where you wanted to go with the conversation about what it implies for included health. But our recipe is basically pretty simple. Figure out how to personalize in a way that the LLMs on their own probably cannot. So let's make it contextual to your health history and your experience. As you've shared it with us and as it has been connected across the platform. We are not developing drugs. We are not selling your data. We will never do that, at least not as long as I'm CEO. Second, let's make it contextual and personalized to your actual benefits experience. So what's covered, what doctors are in network, where you can go next, what other benefits you might have access to. And third, I think, and critically important, let's make sure that we're set up to actually deliver the need. So if you tell, ChatGPT can recommend that you get a strep test or that, that you likely have a UTI, but they're not going to diagnose. They don't want to be in that business for all the reasons we were just talking about and the liability associated with it. And they also don't have the way yet to follow through on the recommendation to where to get service. I'm hopeful that, in partnership with companies like ours, you'll have a more consumer-friendly experience there. But those are the three ways that I know included health can deliver that full experience all the way through. That's personalized, contextual, and ultimately drives the care we need. But the last thing that I sort of want to mention, and one where again I'd like your opinion, is I do think that a human needs to stand in for like the coaching part of this. I've presented Matthew with data. I've helped him understand his condition. I've helped him understand results that might have otherwise been scary and in a language he didn't understand. But now how do I galvanize him towards action? How do I make it easy for him to feel confident in the next step that he needs to take? I don't think the AIs are well set up to do that. They're honestly too agreeable. They're too much like, well, Matthew, great question. Or yes, Matthew, that's a good point you're making. You shouldn't eat fewer than 15 cookies per day, because you want to, so I think that there's an EQ coaching component of this that people are going to respond to.
So I'd like to we can talk the rest of the time about what you raised in that thing, because there's three parts. The second part is incredibly complicated. And there's three parts to the first one, which I just want to know where you guys are and where you're heading. So I am a member of, CalPERS or whatever, or Walmart or whichever company is using.
Yeah.
Sure. I've got three things, right? Number one, I have my benefits. What's covered? What do I need to do? What do it cost me? All that stuff. No one knows that stuff.
Yeah.
Number two, you mentioned I need to get whatever I'm getting. I need to follow through.
I need an order. I need
a whatever. I need a prescription. I need this. And I've just had this thing I wrote about trying to get my appointment with my echocardiogram and having to relay the facts. And
which AI has the facts?
Well, I mean, so there's that. And then third, related to you guys, of course, is that you have a whole phalanx of providers delivering care, not just getting people to other people's providers, delivering care over telehealth. So how are you thinking about using AI? How are you using AI so far, and how are you thinking about using AI in those three domains? Are they maybe they're the same domain, but they seem a little different to me in the flavor.
Yeah. And it's interesting. I'll tell you exactly where we are sort of on the maturity curve and where we're headed on each of those. And it's fun because I have been writing about this, and I have attracted a lot of energy. I'll characterize it that way, from people you and I both know, who are very emotionally on one side of these topics or another. Some people feel like AI should replace all doctors, and not surprisingly, there are a lot of people who say, AI should replace no doctors, and it should only be like a little tool that's sort of in the desk drawer to help assist in better patient care. Anyway, let me sort of crosswalk you with where we are. So first, on the whole notion of understanding your health plan, who's in network, who's out of network, how much you should expect to pay, what the heck coinsurance even means, and how does it apply, what's your deductible, what's left. All of that stuff can and should be in the hands of a terrific AI that can answer your question immediately with high precision any time of the day without getting on the phone. And we have made terrific progress on that question. In fact, we've been live with a model that answers those questions with 95% plus precision for the last now 12 to 18 months. 95%, we started at around 80%, we've been bumping it up, still not good enough. Because ultimately, when it's dollars and cents on the line, people need to be able to feel like they know exactly how much they should expect to pay. They should know exactly what their plan is going to cover. But that takes away a lot of questions and waiting on hold and trying to figure out, where to go next. So on the what does my plan cover and what can I do with my benefits, I think we have made tremendous progress, and I think we're better than anybody else, at least that I'm aware of, including the health plans themselves on this topic.
Well, they're not watch competition. Come on.
Well, I mean, look, in fairness to them, they've also seen this topic coming at them, and if they could avoid, hiring legion, numbers of call center workers, they would like to do that. There is a part of that process, without becoming too weedsy, which is about, is my claim appropriately adjudicated? I think you didn't apply the medical policy correctly. That part of it, we have not tried to take on with AI, and I honestly think will be one of the last things we approach, for the very simple reason that we exist downstream of a partner that's making that decision. So the health plan is making that adjudication, and we have access to all the adjudication rationale, but we ourselves cannot re-adjudicate that claim. And so trying to push an AI into the loop there is probably going to create member friction. So we would expect to continue to be their advocates using humans to prosecute through that work and get people back. And I think I've shared with you in the past, we've literally saved millions of dollars in a case. I'm thinking of the Walmart account now. Millions of dollars have gone back to Walmart associates where they were billed incorrectly on their health plan, just as an example, by fixing this problem. The second area, which is around how do we personalize to your experience and whatever care plan actions you might have and recommendations we've provided you in the past and next steps. We are starting there. We've been sort of recommending best steps for over 2 years now. That's been machine learned pattern process. Really good experience. People like being recommended clear next steps. They like the follow-up activity based on their next steps. What we want to do is create a care plan for everybody, including people who feel well today, but may need to monitor their care into the future, and have that be a dynamic AI-assisted capability. Our AI is called Dot. We want Dot to be your health coach whenever you want it, so that you can factor in new information. Maybe there's a new life event. You're pregnant. Maybe there's a new drug you're taking, and we want Dot to advise on ways to think about measuring the impact of your new blood pressure medication or some new nutritional supplement you're taking. I've seen that work. I'm proud of the work that we're doing. We don't think it's quite good enough to push into public domain yet. It's coming. On the third, which is about actual clinical diagnosis and treatment, here again, I'm super excited. In the back end, we've been helping our clinicians be more efficient, better understand, the health histories of their patients, understand and make sure the right information is in front of them at the right times, and to proceed to the next best steps in the care plan. That work looks good. I would say any provider system, any provider group in the country that's not doing things that are built around scribing and efficiency and recommended next step and billing efficiency, like, you're behind, people, and you need to catch up, and you can get those tools off the shelf. You don't need to call me for them. They're broadly available. So we've been installing those things to good effect. But the part of the clinical delivery, which relates to actually helping members get an answer without having to engage a live clinician, or as a quick adjunct to engaging a live clinician. We're in early days on that, but we expect to lead on it. And the principle that underlies that, and I think this part's super important, is that if there is if you can actually get somebody something faster without creating another billable event, and you can do it safely, you should do it. And here, probably the big first divide I've had in the conversation between the rest of my provider system brethren is we do not want to create billable events just for creating billable events. And I've been sort of following what's coming out of Verona this week. I'm sure you have been too. I think that's where you're going to see all the agentic work from every other software provider to the health systems take a different approach. They're going to do everything around the billable event, but when it comes to ringing the cash register on getting a provider to do something, they're going to force that moment, and they're not going to do what's necessarily in the best interest of the member. And this is just where we're going to take a different path. And our business allows us to do that because we're hired to deliver the best outcomes for members at the lowest possible cost for those members. That's our business. And so, I know that's a lot, but this is where we think it all ties in together.
Yeah. And look, it's just for most of the healthcare system, it's just in their nature. I keep on getting people pinging me about, because I'm doing this thing where I'm trying to track down the cost of a lab. But maybe by the time this comes out, 30 days will be up and I'll have tracked down what the real cost of the lab was. But the number of people who contacted me and said, oh, yes, I was in my free, wellness visit and I mentioned one thing or something was said or I was asked a question, I answered it, I got a script, and all of a sudden I got that free visit became a now paid visit, which hit against my deductible because I got charged money for it.
Isn't that astounding, though? I mean,
that's it. But it's like the scorpion and the frog, right? It's in their nature. That's how those organizations do it. So let me ask you one thing before we start bashing the rest of the US healthcare system, which we're both quite good at.
I actually wasn't going to bash on that. I just want to use that example.
Okay.
And we don't need to go too sort of like technical on every step of it. As a place where an AI that is on the side of the member may not have actually reduced or removed that cost from you, but at least wouldn't have had you surprised on it. It would have said, Matthew, where you are, where you're tracking on so this is considered a preventative. I'm making this up, but it's considered a preventative lab. So you're actually getting it at zero cost, and LabCorp will get paid by your plan, but your plan wants you to be healthy. So this is a wellness visit. But then when there's an underlying diagnosis found, you've now flipped into a finding. And here's why you're being asked to pay 28, 38, whatever that was. And here are your next potential steps on appealing this if you'd like to. That's not a perfect outcome. That's not fixing the US healthcare system, what I just described. But at a minimum, it reduces the frustration to you. Like, I think that you and many other people in the United States understand that we have to pay a few bucks to get healthcare like any other service. What we get pissed off about is that we feel we get nickeled and dimed. The rules get changed on us without notice, that there's nobody we can call and nothing we can do about that. And the first step in fixing that feeling of frustration and disempowerment is at least helping us understand why it actually happened in the first place. Which in your vignette, as you've shared it with me in the past, you don't even know why that happened. And maybe now you do. But I mean, that's crazy that you, as somebody who lives in this world all day, doesn't understand it.
Oh, well, but then, the good news is I get to chase it down, which is.
But how many? Just for giggles, how much time did that take you to do that?
I'm into for the lab one. I'm not quite into hour 3 yet. But every so often, it's like I was spare time on my schedule. I go, let me do this because I can write it up while I'm doing it, which is advantage people. Anyway, let me go back to one tiny thing because I want to get to the last point, right, which is the whole AI for behavior change and coaching.
Yeah, sure.
And that to me is, does it replace doctors? That to me is absolutely fascinating. But one little thing, right, which you guys do a lot of and have always done, right, which is finding the best. If I go back to being in your office in 2012, 13, and you showed me all the data on who were the best specialists in this area, and you had this heart disease, you went to this guy and whatever, you had this cancer, and we went to all the we had the grand round. It was grand rounds in those days.
Yeah, that's right.
And, but there is a lot of friction in the kind of tracking down the right doctor, appointment setting, getting in to see them, all the rest of it. My friend, Sarah Brubaker, she's got married and I've forgotten her last name now, but she wrote a book about this where literally she had was diagnosed with cancer and was told, oh, we can perhaps maybe get someone to see you in 3 weeks. And you're going, what were those 3 weeks like where you couldn't, you were told you had this cancer and no one would talk to you? I mean, that right. kind of thing, right? Happening every day still. And I was just joking about me trying to track down my echocardiogram, referral and having to send the fax and stuff. How much of that does it require your human navigators to be dealing with that, and how much of that can be flipped into the AI? Because I would assume, from a business perspective included, this must be a great opportunity to get those people to do some higher value work than being on the phone hanging out trying to get a
absolutely. So let's break that one down, because I think the notion of let's just talk about the patient workflow. I've been told I need to find a doctor or a specialist for something. I want to understand who's good. I then need to get access to that doctor, book an appointment, and then I need to sort of prepare for and educate that doctor and educate myself. So let's just take those one at a time. But for everybody else's benefit, starting around the time you and I first met, we invested a lot of the precious dollars we had as a company into the machine learning necessary to score roughly 96% of practicing physicians in the country on all of the dimensions of quality that we thought produced a clinical outcome. And we could have an hour just on this segment and what we've learned and what we've discovered that is amazingly predictive, and many things that we thought would matter that really didn't. But that is our earliest application of AI. It was machine learning and pre-transformer, so it wasn't sort of the generative conversational AIs that we're now using, but it was dynamic, highly predictive, self-reinforcing, using neural networks and other models to take in data that was scattered around the world around physician activity and physician performance, and making predictive models, which told us, among other things, that many different doctors produce at different levels of quality based on their actual clinical experience, and not just because they work at a fancy place or that they happen to play golf with some other fancy provider. And so that has made the question of who is the right person to go to a nanosecond answer for us. And it's personalized. So it's a different answer for you than it is for me based on history. And this is sort of like one of our innovations that I'm most proud of. And in a lot of ways, I can say this now, we were 5 or 6 years ahead of our time on really thoroughly interrogating that question. The second part of that workflow is, okay, now I need access. Here's where it gets tricky. And I just want to be honest with you, as I always would be. There are many doctor booking capabilities now available. I've been heartened to see that. And largely, they're revealing inventory to doctors who are not the highest quality doctors. And this actually makes sense if you think about it. Like, if I am somebody who's looking to fill my patient panel, I would try to go and be on the open table for doctors. But just like your favorite restaurant still requires you to call and sort of justify why you should be at that table, it is actually still a manual activity to get access to many high quality centers. Now, we've made one cool structural advancement on this that, to my knowledge, is the only of its kind, which is that we built electronic booking pathways with many provider systems around the country, where in exchange of data, there's no financial transaction here. We have the ability to book our patients with higher speed and higher access. What the provider systems get out of it is they know that we're pre-qualifying that patient based on a clinical interest and a clinical match for their group. So it actually works for everybody. But that problem still requires some old-fashioned elbow grease at times, and making sure that patient is well set up. The third piece, which I described to you, and I'll be quick about this, is, okay, now how do I actually prepare you for the visit? How do I make sure that your agenda for the conversation is set correctly, that you've identified some topics that you want to cover, that your medical records are there ahead of your visit, so that the doctor doesn't walk in the room, and we've probably both had this experience and say, oh, I can't really talk to you until I have that, blood test or that MRI or whatever. And like, well, how do you not have that yet? We make sure that all of those artifacts pre-exist your visit so that it can be a really productive conversation. Now, we just explored one workflow, right? There are so many other workflows that a patient has to go through, but you can see where the AI and the agentic approach allows us to build speed and reduce friction for the member in some cases, and where in other cases, it still requires us to live within the sort of boundaries of the system as it's been created. And we've always had sort of a pragmatism and a humility about where we sit to know that like there are some things that we can say, gosh, we want to only have automatically booked appointments and have it so you can just, push a button on a page and it's auto booked. But if offering that capability comes at a trade to the quality that you're going to ultimately receive, then that's not a shortcut that Included Health is going to make. It also, is a sort of decision that I think a exclusively tech-focused healthcare company might make that costs them long-term scale, because ultimately most provider systems are not set up in order to deliver that level of connectivity. So I know I went deep on that, but this is the sort of stuff that we're really interested in fixing.
Yeah, and I think the first part you said there was super important. And I've looked at a number of companies now who are trying to take that and distribute that as a service more widely than the way you've got it. You're obviously vertically integrated in that, and I think that's fascinating. And I'm always super interested in what's in the black box and how do you really figure people out. And I've seen a couple which I'm going, I'm not. When I've seen what they've been semi behind the curtain, I'm always a little bit unclear. All right, so I'm not sure we're going to have time, Owen, to get to the last bit because we've got like 2 minutes left, and this is a probably 20-hour topic. But you're obviously in the business where you are providing medical care, as well as the other stuff that you're doing. And there's a lot of discussion, especially in the mental health world, where they just got banned in one state, in Illinois. It's this whole concept of, what can a doctor do? What can a doctor be replaced by? This discussion has been going on forever. No one, Bob Wachter told me that he said in 2015, he thought driverless cars would never happen, but by 2025, there would be no need for radiologists. And now he said they can't hire radiologists fast enough. And of course, you can get a driverless car anywhere you want to go in San Francisco. Let's just tease this up. I think I'm in the thing that many of these pieces of work can be done by machines, and that a lot of human machine interaction and some of the voice stuff and the Hippocratic AIs and the ellipses of the world, who do a lot of the sort of educational soft stuff and some of the diagnosis could all be done by machines. And as a provider, you obviously are thinking about what can happen. You've talked much more about supporting providers with AI so far.
No. Well, that would be, I think that's a mischaracterization. I've been talking about putting the power directly in the hands of the members or patients, which I really think is important. But yes, let's tease it up because like many of these topics, I love talking to you about it. And I think I'm probably on the other side, but for a different reason, which is I do think that ultimately humans respond to other humans when being asked to make a behavior change, being asked to do something complicated like take on a surgery or a new treatment. And so there is a role that is absolutely critical for humans. And what is it going to look like? It's going to look very different than the role that a provider has today, which is largely diagnostic and sort of prescribing the treatment. Instead, this is going to be about coaching and influence and advocacy. And I think that's important to talk about.
Yeah, and I'm going to be fascinated to see what that looks like in a few years' time. And I've seen a couple of people who are doing sort of, can we provide the best answer to a nurse or even to a sort of a nurse assistant immediately that's better that they can put into the chat or they can read out or whatever that improves. And that balance is going to be very interesting. I also think we still, God knows how many decades, centuries into this, we still have very little idea what motivates humans, especially the ones who are the most expensive and hardest to motivate and have the most chronic conditions. So why don't we come back and we'll talk about that next time on it?
Great.
I'll have you back shortly. All right. Okay. This is Matthew Holt from the Healthcare Blog. I've been talking with Owen Tripp from Included Health. We got some way through AI, but I guess there's more to be done on that topic. Owen, we'll speak again soon.
Talk to you soon. Bye.